you, or I can put it off.
Whatever is comfortable
Whatever
with you.
with you.
So,
Okay, fine, fine.
yeah. Hello everyone. Welcome to today's session. Today's session is by Dr. Kartikeya Natya. He's going to talk on finger cases on ultrasound, a mixed bag. He's consultant radiologist at KP Diagnostics, Bhilwara, Rajasthan. He himself says that he's a budding sports and musculoskeletal ultrasound and interventional enthusiast, but I would say he's an amazing musculoskeletal ultrasoundologist. He's member of all the prime societies of India. So, and you would realize within a few cases that how amazing ultrasound images can look like, really. So, he can make anything look so beautiful and so pretty. And that's why he's here to show the interesting finger cases to all of us with amazing animations and videos. Kartike, all over to you. I'm also pretty excited for today's session. Thank you for accepting the invitation.
Thank you. Thank you very much, ma'am. Hello everyone. I'm Dr. Kartike, all the way from Bhilwara, Rajasthan. And today is quite an interesting day for me because I think REF started in '96, and when my father was doing his residency, he became part of REF in 1997. So after 28 years, uh, I'm collaborating with the REF. So quite flabbergasted and overwhelmed. So I hope you will like my work. So continuing with the presentation, I have no disclosures, no conflict of interest. So as I start my session, these are two fantastic, very good and very beautiful, uh, I think, the articles that can give you an insight how to look while you evaluate the fingers with detailed anatomy and depiction. You can screenshot it, save. I will just hold for 10-15 seconds. These two articles are phenomenal. So most of my things that I'm going to present have been inspired from these two articles so that you can relate to the things that I'm going to present as of now. So as far as the fingers are concerned and hands are concerned, these are the high yielding areas of our body. We are continuously enthusiastically doing our work, holding the things which involves our day-to-day activities. And these are very prone to repetitive traumas. And I think hand contributes to approximately one-fourth of the musculoskeletal injuries. And as soon as somebody get injured, the nearest point of contact or any hospital, most of the hospitals have ultrasound. So primary modality can be ultrasound. And if we use in a proper way and proper channelized way, we can come out with one of the fantastic results. And but obvious thing is that operator expertise is quite required because to know these tight spaces, the anatomy, it is very important and critical and crucial to understand the pathology and to depict it on your reports and let your hand surgeon know about the effective interpretation and outcome of the disease. So as far as the technique is concerned, we are required with a high frequency transducer, basically ranging from the 15 to 18 megahertz, preferably. But I think in quite good number of cases, up to 12 to 14 megahertz works fine. As far as the positioning of the patient is concerned, it is supposed to be in a way that you understand the anatomy well, and he or she is supposed to be in a relaxed, whether you can keep the hand on a table, or if it's on the right side, you can ask the patient to lie down in a relaxed position, and then you can evaluate the things. Adequate gel application, which we usually call as a gel bed technique, is essential for visualizing small areas and superficial structures. But I will tell you, I use in certain areas, I use water bath technique. I had quite a small plastic box in which I fill the water if there is not a cut injury or anything. If it is there, then I use the sterile box with NS filled, and I make the patient to dip his hands or fingers within that particular water body and then evaluate just by touching the upper surface of the water. You will see all those images in the upcoming sections. Uh, Dynamic evaluation is important so as to know whether the continuity of the tendons or the pulleys is maintained or not. So this particular slide will tell you a brief idea extending from, I'll just start my pointer. Yes. So from the 9L to 18 megahertz, from 9 megahertz to 18 megahertz, how the things differentiate. I think these two segments can work fine for anyone, but if you have a hockey stick probe or higher megahertz probes, it's quite a boon. So if you see 9 megahertz probe, I just have to put it off again. Yes. So that's how the tendons on a 9 megahertz looks like. That's how on the 12 megahertz looks like. It's on the 15 megahertz. And see how beautiful we can see the definitive anatomies and the pulleys and the phalanges, volar plates on 18 megahertz. Now I'm going to talk about a little bit about the zones in the hand, zones of the hand in which we usually depicts our reports. And in the same way, your hand surgeon interpret those reports. So as far as the dorsal side of hand is concerned, we use the Verdun zones of Verdun zone analysis, which is extending from zone 1 to zone 8 and 9, starting from the zone 1, which includes the distal interphalangeal joint, zone 2, which includes middle phalanx, zone 3, which involves the proximal interphalangeal joints, then the 4 proximal phalanx, and the zone 5, which includes the metacarpal joints. Sixth is the dorsometacarpal region, and myotendinous junctions involves the zone 8. So that is how we depict the zones of the hand dorsally. And to talk about the extensor tendon, so basically, once the extensor tendon comes out of the metacarpal MCP joint, it divides into 3 portions. One straight portions go, which is basically central extensor slip, get attached at the base of the middle phalanx dorsally, and the rest of the 2 tendons conjoined with the intrinsic muscles forms the lateral conjoint tendons. Again, mixed together forms a single tendon and ends in the terminal tendon and get attached at the dorsally on the base of the distal phalanx. So these basically, there are certain stabilizer. These are the portions which get stabilized. And at the MCP level, the main stabilizer is your extensor hood. If we talk about the flexor zones, the International Federation of the Society of the Surgery, Hand Surgery, have depicted it into zone 1 to zone 5. Zone 1 basically is the distal insertion of the FDP tendon. Zone 2 includes uh, the entrance of the digital canal up to the attachment of the superficial tendons. Zone 3 basically involves the distal margin of the carpal annular ligament, distal margin of the carpal annular ligament up to the entrance of the digital canal. Zone 4 is basically the area underneath your carpal annular ligament, which is basically your carpal tunnel. And zone 5 is the myotendinous junction of the your flexor tendons. So this is a borrowed image from the articles I make you save a little back. So basically, when we move our probe from MCP joint, proximal MCP joint, that is A to D, we see this way the level and the difference of multiple flexor tendons. So at the level A, we see that the blue one is the FDP and the yellow portion is your FDS, which is flexor digitorum superficialis tendon. Superficialis tendon divides into 2 slips, and your profundus gets invaginated in between as we move more distally. Then finally, what happens is that your FDS, your superficialis tendon, comes underneath and get attached on the both sides of the base of the middle phalanx, and your FDP tendon continues straight and finally get attached at the base of the uh, distal phalanx. And this particular diagram shows you the various pulleys. A pulleys, which are annular pulleys, and crucifix and crisscross pulleys are 3, and annular pulleys are 5, which are basically present at the level of MCP joint, proximal phalanx, body of proximal phalanx, then PIP, then body of your middle phalanx, then at the DIP joints. Basically, these pulleys are stabilizers of the flexor tendons, which, if get ruptured, will lead to the bowstringing, just like an arrow, just like an not arrow, the bowstringing of the tendons. They will just give way superiorly. This is, let me just pause. This is a longitudinal view of the flexor tendons. I'm starting from the distal phalanx and going to the proximal phalanx. This is the attachment of the uh, FDP tendon, and you will see the different attachments of the FDS tendon here and intermittent volar plates. So I'll just start along with. So this is FDP tendon, volar plates, then here is the attachment of FDS, then these are forming common tendon, and these are the volar plates. That is how beautifully with 14 to 18 megahertz pro, we can very well see these tendons. So overall, all in all, these are certain anatomies that I have depicted, and we are going to move around the basic cases that we usually see in our day-to-day practice. I will put a little bit emphasis that working at a tier 3 cities, the added advantage that we have with the ultrasound is that the MRIs, definitely they are there, but not all the MRI and all the centers are equipped with finger and dedicated finger and wrist coils. So they used to perform all these examination in a body coils or head coils or knee coils, which ultimately leads to poor resolutions. So I'll tell you how we can make use of ultrasound and come out with the fantastic results. So I'm going to talk about cases. So starting with the cases, this particular individual had a post road rage knuckle pain. Definitely, he had a fight with someone. He must have hit something with his fist. So this is what, when I evaluated is his extensor hood at the middle finger, I got to see this kind of homogeneity. Now I'll show you a normal image. So this is how your extensor hood is supposed to be look like. This is your extensor tendon. These are both sagittal bands, and underlying metacarpal bone is supposed to be echogenic. So if you see on the affected finger, you'll see that there is inhomogeneity and hypoechoic thickening. The integrity of the sagittal bands are not that clear. Okay, so let me explain you with the schematics. So that is how your extensor tendon is supposed to be. On the ulnar side, you have ulnar sagittal band. On the radial side, you have radial sagittal band. So what will happen when there is a trauma? There will be ultimately rupturing of the sagittal band, and there will be pull of extensor tendon to the side, which is normal. So if a radial sagittal band is torn, which is the most common, I must say, which is the most common band which get affected, the tendon will move towards the ulnar side. Just see this dynamic evaluation of the same individual. So this is your extensor tendon. He's making movements, and there is rupturing of the tendon here in between, which is basically radial sagittal band. I'll just make you see back again. So you can see there is loss of integrity between of the sagittal band here, and this is complete near total tear of radial sagittal band with ulnar deviation of the extensor tendon. So we talked about the zone 5 sagittal band rupture, which is basically a boxer's knuckle. Usually happens in a direct trauma. Most common affected part is the third MCP joint. Reason being, it is the most prominent aspect. If you make your fist, and you will see that the third MCP joint is basically the most prominent one, and ultrasound is best evaluated in transverse plane, and we can ask the patient to make a dynamic flexion of the finger, flexion and extension, that will make us to see the ulnar or the radial deviation. And as far as the ultrasound is concerned, what we can see that there can be band thickening, echogenicity changes, and there can be capsular involvement. And of course, as I made you see, there can be tear. Important point to take note here is that second and the fifth finger have two extensors. So your dislocations of different tendons can be either radial or ulnar or can be both. Coming to the next case. So this particular individual fell on a clenched hand, a little bit of clenched hand, and there what happened is a hyperflexion at the PIP joint. Hyperflexion. So I'm seeing the PIP joint. There is a hypoechoic thickening, which is basically the site of the central slip or central extensor bend with a echogenicity lying in between. So if we see, compare with the normal tendon, central slip, this is how the central slip is supposed to be look like. This is your uh, middle phalanx base where it is supposed to get attached in this crisp manner. So now what is happening with this individual? There is a thickening of the, there is a hypoechoic thickening of the central slip, a little bit of cortical irregularity, which is because of this Avell's fragment of the central slip. So basically this particular pathology is the zone 3 central extensor band rupture, and the deformity which we usually call is the Bottineau deformity. Why it happened? It happened because of the direct trauma and the violent flexion of the PIP joint. And why Bottineau deformity happens? It happens because there is a PIP flexion because extensor affection has been lost, and there is DIP hyperextension because your lateral slips are still intact, which are causing to hyperextend. As far as the ultrasound is concerned, the evaluation of zone 3 injuries are in longitudinal plane. Dynamic evaluation is done by keeping isolated flexion at the DIP joint. And findings, as I told you, can be thickened heterogeneous tendon central band, which can involve both bony avulsion, and it can be without the bony avulsion, only rupturing of the central slip. This is one of the companion case. The patient came with the hyperflexion injury, but she was complaining of continuous pain over the extensor aspect of the PIP joint. When evaluated, the central slip was classically normally attached, but there was a very slight I'm sorry, hypoechogenicity lying over the central slip. So this image I got with the water bath technique. You can very well see the echogenic skin, subcutaneous fat, then the hypoechoic, a little bit hypoechoic area which happened post-trauma, then the central slip and the cortical margins. They are very beautifully seen. When I put the power Doppler for the evaluation, there was extensive hyperemia noted within this particular hypoechogenicity. So what might have happened when the patient had an injury? Instead of getting the central slip affected, there was a slight granulomatous inflammatory process going on sitting over the central slip, which was continuously causing her the pain. So if you use your technique in a very subtle manner, you can see interface very beautifully, and you can very well differentiate whether which part is affected and which part is not. So this particular patient had chronic injury, definitely with a season ball. It was hard cork ball, with which he was playing cricket, and there was a hyperflexion at the DIP. You can see the rest of the fingers are normally looking, and there was a kind of a deformity happening here. So definitely we asked for the X-ray. So we find that there is the index finger was affected, the DIP joint is affected, and there was a juxta-articular sclerosis going on, and there was joint space loss and a subtle, very slight soft tissue thickening. Is this X-ray sufficient? No, we have to go for lateral X-ray. So I went for it, and kaboom, we got a little bit of a fractured fragment avulsed from the dorsal aspect of the base of the distal phalanx. Now, the important thing is whether it's an independent fracture or any other soft injury is also affected. So we asked for the patient was asked for ultrasound, And this is how we got the beautiful image of the extensor tendon. So here is the extensor tendon coming, getting attached to the fractured fragment. This is your middle phalanx, this is your distal phalanx, this is your nail bed, this is your nail matrix, this is your nail. So you can very well see that this particular extensor, distal extensor tendon is still attached to the bony fragment, and it got, due to the hyperflexion at the DIP, got avulsed. Is your imaging sufficient? No. What we have to do? We have to do the dynamic evaluation. We have to ask the patient to dynamically flex. Either you make it flex or ask the patient if he or she can make it happen. Then you measure the distance between the affected portions of the fractured fragment and your distal phalanx. Then you make the patient to go again to the resting stage. Then again, evaluate the distance between. So you have to give the difference between the dynamic resting stage and the dynamic stage into your reports also. So yes, this is a zone 1 terminal extensor band rupture, which is classically known as the mallet finger. The cause, as I told you, it's a hyperforce flexion at the DIP joint, and which ultimately lead to the terminal tendon rupture with or without the bone avulsion. Deformity is known as the mallet finger. Ultrasound is best assessed in these cases in a longitudinal plane. You can get thickening, hypoechogenicity at the avulsed area, and you can get the avulsed fragment, cortical fragment also. So this is a video of the patient case, and I don't think so you need any history. We are coming to the volar aspect or the flexor aspect of the fingers. So you see, once again, I'll just repeat the video back again. So you just notice the ring finger. It's firing like a trigger. So yes, you are correct. This is basically, this pathology is basically a trigger finger. So when we evaluated the patient, what we got was that this is your basically your MCP joint, metacarpophalangeal joint. This is your metacarpal head. This is your base of the uh, proximal phalanx. And these are the common the flexor tendons. This is the flexor digitorum superficialis, and this is the profundus tendon going hand in hand together. And there is a hypoechoic thickening lying over the MCP joint, which is nothing but the level of even pulley. So this is a longitudinal view, this is a cross-sectional view, this is little finger, this is ring finger which is affected, and this is the middle finger. You can very well see that the difference in the thickening of the pulleys as far as the as far as the ring finger is concerned. So we talk about the etiopathogenesis of this particular disease. So taking a normal finger, the above half is your superficialis tendon, deep is your profundi tendons, and this hypoechoic, subtle hypoechoic thickening is your pulley. So basically, pulley comprise of multiple layers. This is avascular sliding layer, which is avascular and having acellular cells, which allows the smooth gliding. Then you have this green colored and yellow colored fibroblastic layer. And this orange layer basically is your vascular layer. So in a normal pulley, this is supposed to look like this. But when there is a pathology comes into picture, there is continuously micro traumas or any other thing which has led to the disruption of these two layers. What will happen is the inner layers and the fibroblastic layers get disrupted, and there is hypertrophy of basically the vascular layer. Now, what will happen? There will be thickening of this overall police segment, and this is going to affect the smooth excursion of the underlying tendon. So yes, trigger finger. So it is basically stenosing tenosynovitis of the A1 pulley causing the tendon trapping or the snapping, which is known as the triggering. And the mechanism involves basically the space conflict happening due to the friction and inflammation, which finally lead to the painful click on extension. Usually the cutoff value we take as the 0.6 mm, uh, and we can find vascularity depending upon the inflammation. So I'll show you how we measure. So we measure the pulley thickness at the three directions, one on the ulnar side, one exactly in the middle, in the middle, and one on the radial side. And we have to mention all the three dimensions, what it measures. So you can very well see it is 0.6 on the ulnar side, then 0.8 mm and 1.3 mm radially. I'm sorry. So there are going to be few additional findings that we can get along with the pulley thickness. We can get a hypoechoic underlying thickening of the flexor tendon complex. We might get only effusion of the pulley. So you can very well see that there is a distal acoustic enhancement going on. This pulley is not, it's just showing effusion, and this particular echogenicity of this particular pulley is quite very different from this. So this actually involves the thickening of the soft tissue and the fibroblastic and the vascular layers of the pulley system. So these are certain cases from my social media handles. So you can get extensive tenosynovial thickening along with vascularity. So yes, this is acutely inflamed thick pulley with underlying entrapped tendon, which is showing quite what we must say. It is quite getting what we stenosed in between the smooth area of flexor tendon. You can get trigger thumb, which involves basically two pulleys, A1 and A2 pulleys, and a oblique pulley. You can get a thickening of A1 pulley. And sometimes you might not get the whole pulley affected. You can get a very eccentric thickening of a pulley, which is basically small nodular focal stenosing tenosynovitis of that particular finger or the affected pulley. Here, as in A1 pulley, the rest of the pulley is quite very well seen. Only this particular segment on one of the side is affected. Now, coming to the another case, this particular individual was blocking a volleyball and got hyperflexion injury at this particular. He was blocking the ball, ball hit and led to the hyperextension injury. You can see a very ecchymosis at the distal finger level and a little bit of swelling. So definitely we asked for an X-ray. So you can see there is a cortical avulsed fragment and a little bit of irregular radiolucency or affected portion in the at the base of distal phalanx. We evaluated the patient on ultrasound. There was normal attachment of the FDS slip on the ulnar side. There was normal attachment of FDS slip on the radial side. You can see that echogenic cortical fragment. But when we evaluate the FDP tendon, we didn't find there was a empty tenosynovial hypoechoic area, which was not showing a normal attachment of the FDP tendon at the distal phalanx. So I'll show you how a normal FDP attachment on a finger looks like. This looks like this. So this is a distal phalanx. It is the adjacent finger of the same individual. You can very well see the FDP attachment. Now, when I make you see this, so there is no attachment of the tendon. So tendon, FDP tendon is somewhere here. This is the avulsed fragment from this portion. So basically, we are dealing with the zone 1 distal FDP rupture, which is basically jersey finger. Why it is happening? It is happening because forceful finger, I'm sorry, extension, passive hyperextension, which is very common in the rugby players and the football players. Because what happens when they entangle the opponent, there is very good chance of their finger getting entrapped between their the t-shirts and their shirts and their bermudas, which finally leads to the extension and forceful flexion injuries at the DIP joint. Usually affected fingers are the second and the third fingers because we try to hold the things from these two fingers only when we are rushing for in kind of a football or rugby uh, games. And it may involve bony avulsion. And we can see a different variety of tendon retraction as far as the jersey fingers or distal FDP tendon tears are concerned. The associated findings can be the tendon thickening, echogenicities, soft tissue edemas. And on ultrasound, we can see the cortical irregularity. There will be empty sheath and there will be retracted tendon stump with the acoustic shadowing, which is basically the bone. So what we can see is the jersey finger can be type 1, type 2, type 3. This is a normal finger. Uh, this is a borrowed image from one of the finest MSK radiologists, Dr. Shairi. So zone 1 is the most affected and the most gruesome injuries in which FDP reaches up to the the proximal MCP joint and somewhere in the palm. Type 2 injuries are somewhere at the level of middle phalanx, which we just saw. And the type 3 injuries are just restricted up to the avulsed fragments just at the level of the A5 annular pulley. So I'm going to show you a companion case. So this is the distal phalanx. This is middle phalanx. There is empty sheath. There is no attachment of the FDP tendon. And there is atratic FDS tendon seen when I evaluated more proximal portion of the same finger. And when I saw there is inhomogenic thickened, it's a chronic case. So there is a very inhomogenic crumbled up hypoechogenicity noted in the mid palm, which a little bit of cortical. So basically this is type 3, type 1, I'm sorry, type 1 jersey finger. You can very well see this is empty, the atretic FDS tendon, and finally this crumbled and retracted FDP tendon in the mid palm level. So this particular case has been known case of FDS tear, got operated somewhere and 1 year back, and he was having persistent swelling at the PIP joint. The important thing with this particular case is due to uh, poor, poorly treated patients and poorly labeled the diagnosis, it ultimately leads to the complex hand injuries. Let me show you the X-ray. The bones itself are quite very normal, except these juxta articular hypoechogenicities, which are basically the attachments of the lateral collateral ligaments at the PIP joint. When we evaluated this patient on the extensor aspect, we found thick central slip with extensive vascularity. It was inflamed chronically. When we see volarly, we found at the PIP joint, there was a hypoechoic soft tissue thickening and the flexor tendon was going above it. It is nothing but the volar plate, which was chronic, fibrotic, swollen over the 1.5 years since the patient got injury. This is basically the radial collateral ligament at the PIP joint. You can see this is hypoechoic thick, and it is quite very thick. I'll show you the normal one along with it. And this was basically the ulnar collateral ligament at the opposite side at the same PIP joint. So this is how the volar plate looks like, and you can very well see how it is looking with this particular patient. So this is your middle phalanx. This is your your middle phalanx, proximal phalanx. This is your volar plate, and the flexor tendons are going above it. So what you can get in a hyper extension injuries, you can get just the rupturing of the volar plate with a mild perivolar plate effusion and peritendinous effusion, hemorrhage, that could be anything, and it could be associated with the rupturing of the pulleys also. Or you can get sometimes avulsion of the bony fragments where the volar plate get attached. Now you see, this is how the normal one looks like. This is just soft tissue avulsion of the volar plate. This is cortical avulsion of the volar plate. And in this particular case, this is chronic, fibrotic, thick. Maybe it might have torn during the acute injury phase, now finally led to the this particular swollen state in the later part of neglected injury. So as far as the volar plate rupture is concerned, this happens because of the hyperextension or the dorsal dislocation of the PIP joint, which usually happens while having direct fall on fingers from a height. Deformity leads to the PIP flexion deformity, and you might get association avulsion fracture at the distal insertion, as I showed you in one of the images. Ultrasound, basically the triangular morphology is lost. The triangular morphology of the volar plate is lost. There can be altered ecotexture, there can be bony fragments associated, and passive PIP hyperextension confirms the complete rupture. If you make a passive hyperextension by putting the probe at the affected joint, you can see that the increase between the joint space and the bone and the volar plate is increasing, and that can be definitely documented within the reports. So this particular case, this guy fell on his outstretched thumb on both his hands. There was something and got entangled between both his hand, but his right thumb got more affected. So when I evaluated his ulnar collateral ligament, there was a gross hypoechoic thickening I found on the attachment site of the ulnar collateral ligament, and definitely there was moderate degree sprain present on the left ulnar collateral ligament also. I'm talking about thumb per se. So in a normal individual, it is supposed to be look like this. This is your first metacarpophalangeal joint, which is basically thumb. This is your first metacarpal. This is your proximal phalanx, and this is the ulnar collateral ligament attachment. So what happened with this particular individual? There might have led to the hyperextension of the uh, thumb from the rest of the hand, which ultimately led to the sprain. When I evaluated the same patient in an oblique manner, I found that the ulnar collateral ligament is eccentrically placed and there is a hypoechogenicity residing adjacent to it and in between it. So then I thought of it to be a gamekeeper's thumb or the gamekeeper's thumb along with a Stenner's lesion, which is basically the adductor aponeurosis. But when I evaluated this particular echogenicity and heteroechogenicity, what I found was that the UCL, definitely there is a complete rupture of the UCL is there. There is myotendinous junction of the adductor aponeurosis was also present. So this particular individual had a complex UCL tear with part Stenner's and myotendinous junction tear of the adductor aponeurosis. So what basically happens is the hyperabduction injuries lead to the UCL tear and associated hyperextension of the first MCP joint. Skier's thumb basically just involves a UCL tear without displacement. If you, I'm sorry, if ulnar collateral ligament get displaced and adductor aponeurosis come in between, it is basically known as the Stenner's lesion, which can only be surgically corrected. This is important. Skier's thumb can be conservatively managed, but the Stenner's, because something has come in between the two of the torn edges of the UCL, so now it is not going to come towards each other by itself. We have to surgically correct it. As far as the ultrasound is concerned, it can be partial and complete injury. We can see the thickening, hypoechoic UCL, along if the inflammation is residing over there, we can find as a Doppler, increased Doppler flow. Sometimes when there is a displaced UCL forms a yo-yo sign, which can be seen on the dynamic MCP flexion dynamic evaluation. So I'll show you. You can very well see this double barreled kind of a thing, which looks like a yo-yo, which is basically a Chinese small thread. Yo-yo is basically kind of a figure of eight like thing with a thread attached to it. So yes, this looks like one. So yes, definitely it is a Stanners lesion, complex Stanners lesion. So this is another case. Yes. So sometimes you can only get a cystic swelling at the level of A1 pulley. So this is the MCP joint. These are the flexor tendons, and this is a cystic swelling. Why I'm saying cystic? Because there is acoustic enhancement, and this is the site of the A1 pulley. If we go for the dynamic evaluation, what we can find is that the lesion is not attached to the flexor tendon complex. It is somewhere above it, and it is not moving along with the dynamic excursion. We can put Doppler to see the integrity, whether it is vascular, avascular, or inflamed. And sometimes what we can do is we can make use of the elastography so that we can differentiate the lesion with hard and the extremely soft surfaces or cystic surfaces. As in this particular thing, the affected segment is blue, which depicts that this is completely fluid filled lesion. So this is nothing but the tenosynovial ganglion, which are the most common hand lesions, which are mostly seen around the wrist joints, both dorsal and volarly. But we can also see along with the tenosynovium of the fingers, the primary location on the volar region of the tendons and the joints. These are usually high yielding and high working individuals, young individuals, and more commonly the women. As far as the Indian context is concerned, women are more affected. Ultrasound shows you an anechoic nodular or polycyclic mass uh, with posterior acoustic enhancement, and you won't see any Doppler if it is not inflamed or not vascular lesion. The key point is to see and look forward to the neck of the lesion so that you can tell your hand surgeon from which particular joint or what is the basically epicenter or the origin of the lesion. Another case. So this particular case is basically a 70-year-old individual. He was diabetic, known diabetic since last 20-25 years, and there was a hypoechoic uh, palmar nodular swelling. It was not affecting basically the flexion and extension of the little finger, but it was kind of forming a stretching contracture-like area over this particular segment of the hand. You can very well see that this is a slightly swollen up or more pronounced as compared to the rest of the hands. So this is nothing but a hypoechoic subcutaneous nodular swelling. On Doppler, you can get internal vascularity depending upon the fibrotic and non-fibrotic components. And when you see the things on the transverse plane, you can see that this is restricted to the subcutaneous plane of the uh, palm, but your flexor tendons are lying beneath it. So it is not affecting the flexion and extension of the finger. This is nothing but the palmar fibromatosis or the Dupuytren contracture, which affects approximately 1 to 2% of the population. And when it get affected, you might get uh, bilateral affection in those individuals. Primarily affected sites are the fourth and the fifth fingers, and it happens, as I told you, it's the individual is 70-year-old. It affects the elderly people. So the clinical course, usually there is a subcutaneous nodule formation. Then finally, the fibrous cords get attached to each other and then finally forms the flexion contracture bands. On ultrasound, you can see as a hypoechoic nodular thickening, which is basically thickening of the palmar aponeurosis. And on dynamic study, you can see the adhesion between the fibromatosis and the flexure tendon if it is present. And usually there is minimal Doppler flow because of more of a fibrous content within the lesion. So this is quite a simple case. This particular lady fell down 3, 4 years back, and she was having a painful nodular swelling at the PIP joint of the index finger. You can very well see this. This is little swelling. So I tried to imagine this particular patient rather than with the gel. I uh, went for the evaluation with a water bath technique. So yes, so this is the index finger, this is the middle finger, uh, this is your ring finger. So I was able to perceive that there is a echogenicity lying in the subcutaneous plane below the subdermal space, and there is a hypoechoic halo around. When I saw the lesion in a longitudinal plane, so it is lying like this. There was a echogenicity with a hypoechoic halo around, but there was no internal vascularity. So this is nothing but a chronic impacted thorn or the foreign body, as it is being what I must say, it is being a uh, plant component. So there was the reactivity of granuloma is more. If it is going to be some other metallic foreign bodies, you or glass foreign bodies, you will see a less of a hypoechoic halo around. So common sites are hands and fingers because whenever you fell down, you try to protect yourself from anything by just keeping your hands in between your body and the surface on which any individual is falling. So on reaction, there is a granuloma formation. On ultrasound, you will see the foreign body with a hypoechoic, which are usually the hyperechoic appearing foreign bodies. They can be of variable shape. They can be at different level. They can be just underneath skin, soft tissue. They can be intratendinous. They can be intra-articular. They can present at any location. And as far as the metallic foreign bodies are concerned, you should go for the just put the Doppler window. You will see the reverberation artifacts. You will see the twinkling artifacts, and you can see the shadowing depending upon the hardness and the intrinsic component composition of that particular foreign body. So usually on perilesional signs are hypoechoic halo with a increased Doppler flow, which is basically foreign body reaction. So this particular individual removed due to some reasons, he must be feeling tight ring finger or something. He removed his ring forcibly 1 year back. Post to that, he developed multiple nodular swelling extending from the zone 4 up to the zone 1, 1, 2, 3. We got an X-ray done and we found that his ring finger is having multiple soft tissue echogenicities and slight thickening of the cortical margins, maybe because of the chronicity of the proximal phalanx, distal half of the proximal phalanx. So when we put him under evaluation on ultrasound, we see multiple hypoechoic avascular nodular thickenings through which your flexor tendons were traversing. Few of the one of the this particular swelling was completely encircling the flexor tendon. You can very well compare this particular thickening with the rest of the other finger tendons. That's how this is. So we asked our plastic surgeons to get them removed. So it was beautifully removed by our plastic surgeons. There were multiple, 3 different nodular swellings. This was the swelling which was completely encircling the flexor tendons. And on histopathology, turned out to be giant cell tumor. So giant cell tumor of the hand or the flexor tendon are the most common true neoplasm of the hands, and which are basically extra-articular extension of the PVNS. So epidemiology is as far as the epidemiology is concerned, this involves the individuals between the age of the 30, 50 years, and there is a predominance of the females. But to be very frank, I must tell you, during my short practice, I've not seen a single female with GCT. Most of my patients are male individuals only. So I don't go with this particular inference of female being having more predominance. As far as the clinical uh, extension of the disease is concerned, there is a slow growing volar masses and may displace the adjacent structure. And also on dynamic evaluation, they may affect that particular uh, routine tendon movement uh, of the area where they are progressively increasing. And they may lead to bone erosions in 10 to 15% of the cases. If they are not growing exophatically and they are going deep adjacent to the bone, they may cause bone erosions also. On ultrasound, you will see them as a solid, well-defined hypoechoic lesions around the tendons with a variable degree of the vascularity depending upon the fibrotic and fibrosis within these GCTs. So this particular lady has a painful tender to touch nodule at this localized area of the middle finger. This is basically the ulnar side of the. So we asked X-ray done. We asked for the X-ray. So this is basically the area which was affected. This is the radial side. This is the ulnar side. You can very well see a hypoechogenicity, subtle hypoechogenicity. Uh, on zoomed on images, there was a cortical scalloping and I'm sorry, not hypoechogenicity. This is basically radiolucency. Radiolucency was seen with a little bit of a soft tissue density lying over here. We went with the ultrasound imaging. There was a hypoechoic nodular swelling, which was causing the scalloping of the underlying uh, bone. As soon as we put the Doppler, there was extensive internal vascularity was noted, and there is a bone scalloping, internal vascularity, and severely tender to touch. This was basically, we labeled it as a glomus tumor or the glomangioma. Basically, these are the hamartomas of the glomus bodies, which are not which are basically arteriovenous anastomosis for the thermoregulations. So, so and primary location of these individuals, affected individuals, are hand, out of which 65% individuals show these lesions in subungual aspects, which is basically the underneath the nail bed at the fingertips. They are associated with severe pain, tenderness, and sometimes causes the nail deformity and their discoloration also. As I told you, they are small, well-defined hypoechoic nodules beneath the nail beds, if you find them there. And bone erosions can be present, and they are associated with the Doppler vascularity. There are few common and uncommon sites of the same tumors, glomus tumors. I'm going to show you up. So, it's a wrongly labeled arrow. So basically, this is the subungual uh, subungual hypoechoic nodule. This is a nail bed, and this is germinal matrix of the nail bed, and it was quite very tender, and it was showing not that much of vascularity as I showed you before. This is another lesion which was lying somewhere here, and it was quite very big, severely tender. It was highly vascular. This is also very uncommon site, and this is another site for the glomus tumor. There is this particular hypoechoic lesion is lying on the volar aspect, extensive vascularity, and it was just adjacent to the attachment of the profundus tendon on the volar side. So these are just some companion cases. I'm sorry for the wrongly labeled arrows. Basically, this particular is the site of this individual, and this particular arrow is somewhere depicting here only. So these are the most common cases that we encounter in our day-to-day practice as far as the ultrasound of the fingers is concerned. But we can look beyond to certain miscellaneous cases also, and we can look beyond of seeing certain pathologies that we see on a day-to-day basis. you can beautifully see the complete nail. One thing, you put a good amount of gel on the nail bed, keep a little bit probe, you can see the dorsal plate, you can see the ventral plate, you can see interplate spaces, you can see the epinechyma or the proximal nail fold, you can see the nail matrix, which is basically the most common side of the clomus tumor, distal phalanx, and the nail bed. And you can very well see the distal nail fold at the hyponychium. So if you're finding any foreign body impacted or a crooked nail, you can very well evaluate the complete nail also and report on your give it on your reports. This is another miscellaneous case. This particular individual had a thorn injury which he neglected over the few months. We asked for the X-ray done. There was a soft tissue density at the level of the PIP joint. And on the zoomed on images, you can very well see that there is loss of loss of joint space, cortical irregularities, uh, juxta-articular radiolucencies, which is basically due to the hyperemia of the of the vessels, interosseous vessels, and there is periarticular erosions also. When we put the patient under our probe for ultrasound, we see there is a dirty looking echogenic if collection is lying in the affected joint space. There is cortical erosions, and on Doppler there was extensive vascularity. This is nothing but septic arthritis. This particular lady, it's quite uncommon case. She got this particular area, got thorn prick few years back. Then she had a multiple sitting of skin grafting. I think 4 or 5 sittings of the skin grafting, but she complains of continuously having discharge of pus and blood intermittently from this particular site. We got a X-ray done. There was no significant or no bony changes were there, no soft tissue thickening or anything. But when we took the patient under ultrasound, we evaluated under a gel bath technique, and we see that this is how the skin is supposed to look like. The affected segment shows a dermal thickening with a little bit of scarring. And when we put the Doppler, there was juxta-lesional, just beneath the lesion, there was an increased vascularity. Rest of the tendons were absolutely fine. So this is basically scarred area and a hypoechogenicity of the finger pulp. So we labeled it as a infected granulomatous lesion and put a query about it being a pyogenic granuloma. They got a punch biopsy done, and finally it resulted into definitely into a pyogenic granuloma. I think this is going to be my last case for today. This lady somehow badly got her amputated finger while she was a farmer and got her finger amputated during one of the farming activities. But she came up with a tender pain at the tip of these both the tip of the amputated site. She was not complaining of any discharge, not any discharge or redness or anything, but it's just resting and burning sensation and pain over the tip of the fingers. When we evaluated the patient, what we find on one of the radial side, very thin hypoechoic structure is terminating into a globular hypoechoic area, and on the contralateral side, a similar kind of a hypoechoic structure was terminating into irregular invaginating hypoechoic lesion, and it was associated with a little bit of a hyperemia adjacently. The finger uh, remaining finger pulp and stump was absolutely fine. There was no soft tissue pathology. So what might have happened was during the transaction and her uh, treatment, what had led to that, these particular digital nerves terminated into a neuromatous thickening, which basically leads to the Sunderland's classification of 4, which ultimately lead to the neuromatous, simple neuromatous, and invaginated neuromatous thickening, which are actually leading to the phantom pain sensation of this finger. So, to conclude my talk for today, hands and fingers are highly vulnerable to traumas and repetitive stress and the degenerative injuries. So, we definitely have to think about routinely evaluating these individuals who come to your ultrasound clinic. Ultrasound is easily accessible, dynamic, and excellent tool for superficial structures and finger evaluation. I think high frequency probes make your diagnosis more elaborative and more definitive, but uh, a correct positioning and critical thinking about your history of your patients can lead to a definitive diagnosis on on transducers with a bandwidth of 12 to 14 megahertz also. Operator expertise. Yes, an individual who knows about all these anatomies is very essential, and interpretation depends on the knowledge of the normal anatomy and the pathological anatomy. And once you know the pathology, how they looks like, the articles which I have shown you, if you go through those articles, you will get an idea how rupture looks like, how ligamentous injuries look like, how fibrotic lesions, grade 1 strains, sprain injuries look like, how complete tear looks like, how you can put your dynamic evaluation into picture, how to differentiate tumors and cysts and the foreign bodies, and that finally enables you to timely diagnose and guide for the treatment to your hand surgeon or your plastic surgeons. So my final take home message is just master your anatomy, apply the correct technique, use dynamic assessment, and yes, always correlate clinically, which what means that you ask for the history, go for the definitive mode of dynamics of the trauma, and then finally to the conclude to the diagnosis. So thank you very much for this wonderful opportunity, for giving me on the platform of REF. Over to you, Ankita ma'am.
Thank